Hello everyone, welcome to my video on challenging concepts on the integumentary system. So it's chapter 5 of the Marieb's Human Anatomy and Physiology textbook. So our biggest organ in our body is our skin, and that is an organ belonging to the integumentary system. So our skin is also the cutaneous membrane, which we alluded to in chapter 4's challenging concepts, tissues chapter concepts. So we have the epithelium as well as the connective tissue. In the epithelial part is the epidermis, the top layer of our skin. That's made up by keratinized, stratified, squamous epithelium. So stratified squamous epithelium protects underlying layer from abrasion. The dermis is fibrous connective tissue. We'll talk about it in a couple of slides. It's areolar connective tissue on top and then dense irregular connective tissue below it. Then hypodermis is not really part of the skin, it's below the skin. Hypo means lower, so it's below. You may have also heard of another term, subcutaneous, subcut. In terms of fluids or injections, they may have heard of that term. That's in reference to the hypodermis. So it's mainly made up of adipose connective tissue. So in terms of the epidermal layers, in certain parts we have 5 layers within the epidermis. At no means am I encouraging this, but this is just a little acronym that helps students remember these layers. It actually comes from the top down. So CLGSB, come, let's get sunburned. Again, I do not recommend it at all, right? But it just helps us to remember that the order in which they would be placed from outside inwards is come, let's get sunburned. We're going to talk in terms of how it comes out from the innermost outerwards, because that's the way the cells develop, right? The most mitotically active cells are the lowest layer of the epidermis. So that's stratum basale. Some books also will describe it as stratum germinativum. So it has the stem cells. So there's mitotically active cells. They will divide and push upwards. The next layer up is stratum spinosum, spinosum, so spiny keratinocytes. So they basically look like little pufferfish or porcupines, if you will. The next layer up is called stratum granulosum. The cells have a lot of granules within the cells. The next layer up is only found in some tissues, but you can think about the significance of that. I always talk about Lucifer when I'm in person with students. That kind of helps students remember Lucifer is the devil, so think about death. So here, predominant in this layer are cells that are dying, undergoing apoptosis, programmed cell death. And the topmost layer is stratum corneum. That's the most, actually kind of the thickest most. Those are dead cells. There are no nuclei, no organelles that are found here. And this is what sloughs off, breaks off. It can be dandruff and dander and so on. This is made up of corneum cells. So let's quickly go through some epidermal cells. So the two predominant ones is keratinocytes, that's the most. Which basically gives us the name for our epidermis, the epithelium, keratinized, stratified, squamous epithelium, right? And then we also have melanocytes, which produce one of the pigments in our skin, the melanin. We also have other cells like the Langerhans cells. These are the immune cells that are found in our skin. You may have heard of it, and we will talk about it also later on in our endocrine chapter, islets of Langerhans. It was the same person who described it. That's in the pancreas, which produces the insulin as well as glucagon. Here, these Langerhans cells are immune cells. We also have some other cells for different receptor cells. Touch receptor cells are Merkel cells. So the next layer down is the dermis. It's strong, flexible. It contains nerve fibers, blood vessels, as well as lymphatic vessels. If you recall from the tissues lecture, epithelium does not have blood vessels, so it depends on the connective tissue underneath for its blood supply. So if we remove just the epidermis without removing any part of the dermis, we will not bleed. We only bleed when it goes below. So you might have seen that happen to yourself. You might have had a little scrape. It didn't bleed at all. That's because you only took off your epidermis cells. You did not go into the dermis. The dermis itself can be divided into two layers, papillary layer on top and the reticular layer. About 80% of the dermis, thickness-wise, is a reticular layer. So let's look at the papillary layer first, papillary layer first. So that's the top 20%. That's closest to our stratum basale of the epidermis. Here it is made up of areolar connective tissue. Papillary layer, also you can find dermal papillae. Dermal papillae are these little finger-like projections. Anywhere you see finger-like projections, they are trying to increase surface area. We'll see them in digestive tracts. We have the whole membrane, which a whole surface of the inner surface of the digestive tract, which has these folds. The villi, for example, they will increase surface area. So they have finger-like projections rather. And even on the cells themselves, the simple columnar cells on the cell surface of each cell also have finger-like foldings of their cell membrane, microvilli. So those all increase surface area. Here too, it increases surface area. So different structures can be found within it. It also helps for the epidermis to be attached better. So within its dermal papillae, we'll find capillary loops. We'll also find some touch receptors. In this picture, it's not shown. It's similar to this this finger-like, thumbprint-like view. This is Pacinian corpuscle. You can think of a miniature version of that within the dermal papillae. That will be the Meissner corpuscle, which is for touch reception. We also have some free nerve endings which can be found within the dermal papillae. The reticular layer is deeper in. It is mainly made up of dense, irregular connective tissue, so it can absorb strain in multiple directions. It has a lot of blood vessels. It also has some adipose connective tissue. The bulb of the hair follicle also can be found within the reticular layer. Hair follicle are epithelial cells that have gone in deep into the dermal layer. We also find glands such as our sweat glands, sudoriferous glands. We also find ceruminous ceruminous glands and other glands which can be found within it, sebaceous glands and so on. We have the Pacinian corpuscle. That's this finger-print-like structure. That's for deep pressure and pain. Okay, so it's deeper in, so you can sense that, or you can sense pain and pressure. So, some skin color diagnosis. So, some terminology you might want to know from this lab. In terms of what gives us our skin color, it is of course melanin and keratin, as well as hemoglobin gives the different shades in our skin coloring. These are other colorings, right, which can give us names or even diagnoses which talk about underlying some other conditions that may be present. So cyanosis is blue coloration, discoloration of our skin, which indicates low oxygen in hemoglobin. Then erythema is redness, usually indicates fever, inflammation, or even an allergic reaction. Paler is kind of the blanching effect, which is lighter color, usually shows signs of anemia or low blood pressure. Sometimes you may think about people, the color left their face when they saw something fearful, for example. That can be um, a reflex. Jaundice, the yellow coloration of our skin, usually because of some sort of a liver disorder or increased red blood cell breakdown, amongst other few others. Bronzing, that gives a bronze tinge to our skin. Usually it is very commonly associated with Addison's disease, where we have inadequate production of steroid hormones by the adrenal glands. Then bruises, we can also see different colors depending on um, the age of the wound, of the bruise. It's basically clotted blood, and sometimes when they reabsorb, they can change color too. In terms of derivatives of epidermis, so we have hair follicles, nails, sweat glands, the sudoriferous glands, and then sebaceous glands. These are all uh, derivatives of epidermis. So we'll look at the glands next. We have sebaceous glands. Sebum is oily substance, so it's like the natural moisturizer of our skin. So the sebaceous glands will produce sebum, which is a natural moisturizer, right? So it makes our skin supple, also helps us to maintain water or prevent water loss, as well as it's bactericidal, so it can kill off bacteria. When we suffer with blocked glands, that's when we can develop acne because of inflammation of these glands. Then sudoriferous are the sweat glands. Please note there are two types, eccrine sudoriferous, beg your pardon, or eccrine sweat glands. These are the ones we generally use just for thermoregulation to cool down our body. While apocrine sweat glands, those are found in places like our groin and armpits. Those what give us our body odor or produce pheromones. Then we also have ceruminous glands. This is mainly found in our ear canal. It's like the waxy substance that they produce. The wax in our ear is when this collects and hardens. Usually, the cerumen just waterproofs our ear canal and tries to help removal of other cell debris and stuff. Then skin cancer is what I want to just allude on in this chapter. It's the most common form of cancer. It is treatable if caught early. Some common types of cancer are basal cell carcinoma, so basal cell stratum basale, that's where it comes from, so originates from stratum germinativum, which is another name for stratum basale. Then squamous cell carcinoma, again talking about epithelium, which is squamous epithelium, right? Stratified squamous epithelium. This is mainly involved in the superficial layers of the epidermis, and we've all heard of melanomas. This can begin as a mole, and then it can spread. When it spreads is when it can become dangerous. If caught early, again, it's 100%. It can be cured. In terms of melanomas, we usually have an ABCE of melanomas. We look at the asymmetry of the melanoma. Is it equal on both sides? Then border, we look at if it's smooth or irregular. Then color, is there any discoloration so it's uniform? Diameter, how big is it? If it's small, less than a quarter inch, we are generally thinking benign. If it's larger, we are concerned and we want to get it examined. If it changes size, shape, or color, that's the E part, evolving, that also can be a sign of a carcinoma a, rather than a benign change. Let's talk about burns next. There are 4 degrees of burn. First degree just stays within the epidermis. So usually this is the most common sunburns usually are first degree, not only, sometimes we do have second degree burns that are caused from sunburn. Here we only have redness, some pain, slight edema, and usually heals quickly and does not leave any scars. While second degree burns, so here's, you can see a normal skin, and then first degree burns, pinkish reddish discoloration. Second degree burn are sometimes called partial thickness burns. They have gone beyond the epidermis into the dermis. Okay, and here one sign of that is if it blisters. If the sunburn is blistering, that's a second degree burn. Okay, and it's usually painful, even more painful than the first degree burn, and they slowly heal, and a lot of times they can even cause scars to be left behind. Here you can see that's a nice big blister you can see there, so that's a second degree burn. Third degree burn, if you want to turn away for the picture and just listen, you're welcome to. It is going to get deeper into the skin, so now it's full thickness, it's gone beyond the dermis, so into the hypodermis, even into the muscle, right? So here we often require skin grafts because we've virtually lost the skin, so it needs to be replaced. And it can cause fibrosis, which is non-functioning tissue that's been replaced, right? It's not dead tissue, but it's just not functioning, and cause a severe disfigurement. Here is a burn, third degree burn. You can see the yellow is the fat, some of the red is muscle, so it's gone into that deeper. And then fourth degrees, when we talk about, it's gone all the way past the muscle as well to bone, right? That's obviously the most severe. Usually death occurs not burn directly, but because of either fluid loss or infection, or even toxic effects of the burn tissue which has gone into our body and systematic spread of it. So critical if 25% of our body has second degree burns. If it's third degree burns, it's considered critical. Even the lesser scale of our body is spread out. In terms of analyzing how much is our body, so for example, if you think of the hand of that person is like 1%, roughly 1% of their skin is the same size as their handprint, right? Another rule is in rule of nines, it's called. Head is 9% of their body skin, arms are 9% each, and then the back, the front, the trunk, the front of the trunk, the back of the trunk, each of the legs are 18% each, right? So that's a kind of an estimate as well. We try to calculate how much of the body has been affected. Treatment can be varied depending on the degree of burn. Debridement is the removal of the burn skin. Antibiotics because of preventing infection. We may need to temporarily cover that area with moistened dressing because we want to, because it can dry up easily. If it's third degree burns, we also need to, or fourth even, we have to consider skin grafts as well. So that's a quick recap of some challenging topics within Chapter 4, the Integumentary System. I will hope you found this useful. I will catch you in another video. Have a great day.